Question 80. A 25-year-old woman experienced a tonic-clonic or grand mal seizure for the second time, and her neurologist decided to start her on antileptic therapy. From the following list, recommend a suitable antileptic drug treatment for this woman. Okay, so this woman is suffering from these seizures. So a tonic-clonic seizure is one that has aspects of both a tonic seizure and a clonic seizure, hence the name. So the tonic phase is characterized by this sudden loss of consciousness where the muscles will stiffen up. That usually lasts for a few seconds to a minute. Then you have the clonic phase, which is characterized by this rhythmic jerking muscle movements. There's sometimes, frothing at the mouth. Sometimes when you hear about people having a seizure, that's kind of the stereotypical example. And I'd say a tonic-clonic seizure is probably the most stereotypical of a seizure. So when they're going through the clonic phase, you can have tongue biting, you can have incontinence as well, so not pleasant for them, and that stage can last for a few minutes. So when we're trying to decide what drug to give this woman, we need to have a look at her situation. So she's 25 years of age. So because of that, even if she says that she's not looking to have children, or even if she's just not interested, we have to take into account that she is of childbearing age. So we need to be careful at giving her any kind of drugs that would be teratogenic. So teratogens are drugs that, if given to a woman who is pregnant, they can disturb the development of the embryo fetus. I think the most classic example most people know about is the thalidomide incident, where a lot of children were born with deformed arms, deformed legs. Obviously it's a horrible thing to happen, which can massively impact their life moving forward. So it's something we want to prevent as much as possible. We also need to take into account the type of seizure she's experiencing. So different types of medication will work for different seizures. Whether the particular drug in question is convenient for her dosing convenience, as well as the safety profile. So with that, let's go through these. And the first one we have is lamotrigine. And this, so I've kind of given it away straight away, haven't I? This is actually the correct answer. So the great thing about lamotrigine is that it's not a teratogenic. It doesn't. A lot of anti-epileptic medication can be, whereas lamotrigine is one of the few that doesn't. So it's very favourable for women, particularly of this kind of age group, to avoid those kind of situations from occurring. It's useful at treating both partial and generalized tonic-clonic seizures. So this particular seizure we will assume is a generalized tonic-clonic seizure, so perfect for that. It tends to be quite well tolerated, low instance of adverse side effects, and obviously we're trying to avoid that as much as possible. And it can be used alone as a monotherapy, so you don't need to be adding other medication for it. So in this particular case, lamotrigine would be the first drug of choice. So if we go through the other ones, so we have lorazepam. So lorazepam is a benzodiazepine, and it can sometimes be used to stop acute seizures, but it's not typically used for long-term seizure control. In the case of our patient, this is the second time that she's experienced a seizure, so we can assume that this is unfortunately something that might be plaguing her moving forward. So we don't want to be giving her a drug that's just going to treat her as a one-off. We want something to help manage those symptoms. Phenobarbital. So this one is a little bit of an older anti-epileptic drug, tends not to be used too much nowadays, and the reason for that is that it has a higher risk of sedation, and it also there's some evidence to show that it can impair cognitive abilities. So it's usually a drug that's reserved when other treatments have failed because of all the side effects you can have. So that's, I guess, I don't want to say last resort, but more like second or third line therapy. Phenytoin. So this is an effective drug for tonic-clonic seizures, but it has quite a narrow therapeutic index, and it can cause pretty unfavorable side effects. It can cause gingival hyperplasia, hirsutism, so that's when you get facial hair on a female growing, which a lot of women, especially young women, obviously not going to be particularly fond of, and it also has teratogenic properties. And then finally, sodium valproate. So this is effective for a very broad range of different seizure types. However, it has a very significant risk of teratogenicity. So you wouldn't typically give it for a woman of childbearing age. So the correct answer is lamotrigine. Question 81. If she were prescribed carbamazepine, which one of the following is an important risk factor? Okay, so carbamazepine is an anti-epileptic drug. It primarily works by blocking voltage-gated sodium channels, and this action reduces the repetitive firing of action potentials, and that's what we use to help treat, the epilepsy, because that's the too many neurons firing rapidly. Question 81. If she were prescribed carbamazepine, which one of the following is an important risk? So carbamazepine works by inhibiting voltage-gated channels, and in doing this, it decreases the frequency of action potentials, and it's this effect that has the benefit of reducing these epileptic symptoms that the patient is suffering. Now, as for the question itself, I don't like this question because 3 of these 5 are risk factors, and this question is basically judging you on your ability to define which one is seen as an important risk. And personally, it's a very strange criteria to have, because which one is the most important risk to me is more based on the individual patient, and we don't know a huge amount about the patient, and we're expected to make this judgment call. So I'll kind of talk through this. So anemia. So carbamazepine can cause certain hematological side effects. So it can cause something called leukopenia. So that's when you have a reduction in the amount of white blood cells. And it can also cause thrombocytopenia, which reduces the amount of functional red blood cells. So these are very similar conditions to anemia, but the devil's in the detail. It isn't technically anemia. Question 81. If she were prescribed carbamazepine, which one of the following is an important risk? Okay, so carbamazepine is a voltage-gated inhibitor. So it inhibits these voltage channels, which reduces the amount of action potentials that are sent and the frequency with which they are sent, which helps to alleviate some of the epileptic symptoms. Now, in regards to this question, I actually don't like it, because it's asking you to decide which one of the following is an important risk. Technically, 3 of these are risk factors, and I would argue 2 of them are important risks, and the 3rd one potentially in certain patients. And we're not given a huge amount about this patient, so we're just kind of meant to assume which one is the most important, which I'm not a big fan of, but let's go through this. So anemia. So carbamazepine can cause hematological side effects. So it can cause a condition known as leukopenia, which reduces the amount of white blood cells, and it can also cause a condition called thrombocytopenia, and this is characterized by low platelet count in the blood. However, neither of these are technically considered anemia, as anemia is defined by a deficiency of red blood cells or hemoglobin in the blood. So it does affect components of your blood, but not specifically anemia. So it's not that one. And next we have constipation. So constipation is a side effect of carbamazepine. However, because it's seen as a relatively benign side effect, we are meant to make the assumption that constipation is not an important risk. So it's not that. So the correct answer to this actually is contraceptive failure. So carbamazepine significantly reduces the effectiveness of hormonal contraceptives such as birth control pills, and it does this because it induces hepatic enzymes, so specifically cytochrome P45, which are responsible for the metabolism of estrogen and progesterone. So this leads to decreased contraceptive efficacy and an increased risk of unintended pregnancy. So this is meant to be the important risk, which I will agree with. This is an important risk. Where I get a bit tied up with it is because The next one is depression, and carbamazepine has been shown to increase the risk of depression, especially in patients that are exacerbating it. And personally for me, again, we don't know too much about this patient other than that she is a woman of childbearing age. But if she is someone who has a history of depression, who has potential suicidal ideation, I would personally consider that a higher risk factor than contraceptive failure. But I suppose contraceptive failure is seen as a more significant risk than the risk of depression. Beyond that, I can't really give too much as to why. I would personally say that they're both pretty big risks, and I would reword this question to which two of the following are important risks, but that's just me. I'm just teaching you how to pass the exams and to think the way that the examiners think. And then the final one is inhibition of drug metabolism. So quite the opposite. Carbamazepine actually induces the hepatic cytochrome enzymes, which will lead to acceleration of its own metabolism and of metabolism of other drugs. So yes, it does involve drug interactions, but it's the induction of drug metabolism, not the inhibition of drug metabolism. Question 82, and apologies, I'll probably keep bitching because I really don't like this section of the exam. I don't think it's very well worded, but we'll go through this and we'll try to explain what's going on. So, if she were prescribed carbamazepine, which two of the following are important counselling points? So, constipation is a common side effect. So, this is a relatively common side effect of carbamazepine. However, in the context of this question, we are meant to rank the most important ones and pick the two most important. So this would fall out of the purview of the two big points that you would want to mention. Not a big fan of how it's worded, because personally, if there was a risk of constipation, I would warn the patient about it. But in the context of this question, that's not one of the correct answers. Her treatment will be lifelong. In some patients, this is the case, but it depends on the underlying condition and also, more importantly, on how well they respond to medication. So some patients with epileptic issues, when they're started on carbamazepine, will be on it for life, but that's dependent on the patient, and it's not guaranteed that they'll be on it for life, so that's not one of the correct answers. Her treatment will not affect conception. So as we mentioned previously, carbamazepine reduces the effectiveness of hormonal contraceptives, which increase the risk of contraceptive failure. Personally, I think this is a bit ambiguously worded, because if you're going to increase the risk of unintended pregnancy, I personally would say that that is affecting conception. However, the impression I'm getting is that when they're asking whether or not it will affect conception, what they're instead asking is, will this drug reduce the ability to get pregnant, which is a no. But again, I don't think it's worded particularly well, and you kind of have to try and figure out what they're actually asking you. She should be advised to use barrier contraception. So this is kind of carrying on, so this would be one of the correct answers. So because it increases the risk of unintended pregnancy, because it affects the induction of enzymes that metabolize hormonal hormones that affect conceptual hormones, especially with the combined contraceptive pill. While you're on carbamazepine, it is very important that they are using barriers. So advise them to use condoms. I always find it strange that they use barrier contraceptions. I know that there's other types of contraception other than condoms, but come on, 99% of people, when they're thinking of condoms, they're not thinking of other stuff. But I suppose it's important for the few people that would use something other condoms. So it's very important, because she's of childbearing years, that she is warned that if she's on birth control, there's a risk that it might not work. She should report any sore throat symptoms to her doctor. That is really terribly worded. She should report any sore throat to her doctor. That should be, she should report any sore throat symptoms to her doctor, or she should report a sore throat to her doctor. I'm just being a grammar Nazi now. Carbamazepine, yeah, this is one. As we discussed earlier, it can cause certain hematological side effects, so such as leukopenia or thrombocytopenia. So if the patient starts to suffer from leukopenia, they're going to have a decreased white blood cell count. Because their immune system is therefore now compromised, this can increase the risk of infection. So if the patient starts to develop a sore throat after starting carbamazepine, this could be indicative that they are starting to suffer from leukopenia. So it's very important that they go to the doctors, let them know that this is a side effect that is starting to occur, and if it's significantly impacting them, then that's the point at which we might start considering a different kind of medication that doesn't have such a effect on the white blood cell count. So she should take it at the first sign of attack. No, so this isn't like salbutamol. Carbamazepine is a maintenance therapy and it's used to prevent seizures. You don't take it as you're having a seizure attack, and also a lot of times seizures can come on quite rapidly. There's not really any indication it's about to come on. So trying to tell a patient, oh, if you think a seizure is about to come, take this pill, it's not going to be helpful. So you want them to be on it permanently to try and prevent that from happening in the first place. She will find it difficult to sleep. Not a common side effect. Again, very rarely that might happen, but it's not something that we typically associate with carbamazepine. And finally, she should avoid taking aspirin-containing medicines. So it's generally a good idea to avoid taking aspirin medicines without consulting a doctor in the first place, depending on what other underlying health problems you might have, but it's not a specific counselling point in relation to carbamazepine, so it would not be that as the correct answer either. Question 83. During therapy, she has seen her neurologist and wishes to become pregnant whilst taking carbamazepine. So now it comes full circle, and I suppose this is the one saving grace of this test is you can go back. So if you came to this question, that would give you a bit of a hint. Okay, maybe some of the other things that I'm looking out for is this pregnancy associated risk. Again, I'm still not a big fan of it being worded the way it is, and you having to basically go back and get knowledge later down the line, but it is what it is. So anyway, the patient has made a fully informed decision to stay on carbamazepine. Which one of the following should she be prescribed? Question 83. During therapy, she has seen her neurologist and wishes to become pregnant whilst taking carbamazepine. So now it starts to become full circle why so many of the previous questions were talking about pregnancy and the fact that she's of childbearing years. And I suppose the one benefit of a question paper like this is if you came to this question, you could go back and then change your answer. Gives you a little bit of hint as to what they're looking at, but still not the biggest fan of how it's worded. So the patient has made a fully informed decision to stay on carbamazepine. Which one of the following should she be prescribed? So cholecalciferol, also known as vitamin D. So it's a good supplement to take. If you can, I recommend most people take it, but it's not specifically important for overall health, and it's not specifically recommended for a patient on carbamazepine. Folic acid. This kind of gave it away a little bit. This is the correct answer. So folic acid is really, really useful, not just in patients taking carbamazepine, but any woman undergoing pregnancy. Folic acid is the source of DNA creation, and it helps to reduce certain neural tube defects like spina bifida and cephaly, and it reduces the risk of other complications. So it reduces the risk of miscarriage, cleft lip and palate, and other pregnancy complications. Now, whilst carbamazepine is not particularly teratogenic, especially compared to other anti-epileptic medication, it does still carry a slight risk of those teratogenic properties. So taking folic acid while she's on carbamazepine can decrease the risk of that. In particular, one of the big problems with carbamazepine is that it can increase the risk of spina bifida. Now, we can solve this if a baby is born with it. We do have surgical procedures to deal with it, but why would we take the risk if there is something we can do to prevent it from happening in the first place? I mean, even when you can fix a problem, there's always going to be a risk of complications with surgery. There's always going to be a risk of all kinds of problems. So prevention is always better than cure. So it is highly recommended that we give this patient folic acid during pregnancy. Retinoic acid. So retinoic acid is, I should have actually put this here, also known as vitamin A. So the problem with vitamin A is if you take it in excessive levels, it can actually be harmful to the baby. And kind of the same with most drugs, really. You always want to make sure you're not overdoing it. You can overdose on everything, which is why you should always read the label or consult your doctor or a nutrition, or in all honesty, if you're intelligent enough, can actually look through it, just Google it or ChatGPT or something, and you can probably find some good information on it. But vitamin A, a big problem with this is if you have excessive levels, it can increase the risk of birth defects. So it's not something that we would recommend on a patient who is pregnant. Next, we have vitamin A. And you might be thinking, hang on, I thought retinoic acid was vitamin A. And in the wise words of Blackadder, yes and no. So retinoic acid is a metabolite of vitamin A. So it's the active form of vitamin A in the body, whereas vitamin A is the fat-soluble vitamin that you find in foods that you eat. So they're almost the same thing, but ever so slightly not. I did not explain that very well, did I? But vitamin A, very similar to retinoic acid. You would expect it's basically the same thing. Excessive levels of vitamin A can be harmful, increase the risk of defects, so no. And then finally, vitamin K. So vitamin K is not specifically recommended for women who want to be getting pregnant, and not specific for a woman taking carbamazepine. So vitamin K, if you've gone through hematology before, very important for blood clotting. So it is something that is associated more with hematological issues, not specific for a patient getting pregnant, and not specific for one taking carbamazepine. So just a little bit on vitamin A and retinoic acid, so there's no confusion. So vitamin A is obtained from the diet in the form of what is known as retinol esters. These are hydrolyzed to retinol in the intestinal mucosa, and it's converted then to retinol through a series of enzymatic reactions. So this is what I mean about them. They're not quite the same thing. One is like the pre of the other, the metabolite of the other, but because one is converted to the other in the body, it's why a lot of the times you'll see retinoic acid described as vitamin A, even though it's ever so slightly different. But hopefully that clears it up a little bit. Question 84. Oh my god, the grammar for this. Okay. Several months later, she complained of itching and nausea, and was found to be jaundiced with a liver function test revealing the following. Okay, so bilirubin is what's produced during the breakdown of blood, and that can be indicative of liver disease. And we can see that the bilirubin is elevated, so that's pointing us towards there being something wrong with the liver. Alkaline phosphatase, that's found throughout the body, but particularly again, liver, bone, kidneys, and intestines. This is within the normal range. So normally alkaline phosphatase, yes, it can be indicative of liver disease, sometimes bone disease. So this is in the normal range. So it's less likely that there's something going wrong with the bones. Alanine aminotransferase. So again, that's another enzyme that's found predominantly in the liver, and that can be quite indicative of liver damage or inflammation, particularly hepatitis or liver psoriasis. So this is incredibly elevated. So again, pointing us towards a liver problem, potentially inflammatory in nature. Aspartate aminotransferase. So again, enzyme found throughout the body, like the liver, can also be found in the heart, muscles, and kidneys. So elevated levels of AST can indicate liver damage. It can also potentially indicate a heart attack or some kind of muscle damage. Again, this is incredibly elevated, and given the previous readings, we are inclined to think that it's more of a liver problem than potentially a cardiac problem. Gamma glutamyl transpeptidase. So this is, sound like a broken record, high concentrations in the liver and the bile duct. So this tends to indicate either liver disease or some kind of bile duct obstruction. This was in the normal range, so it makes it less likely that it's some kind of bile duct obstruction and more likely that it's some other kind of liver disease. And then we have the international normalized ratio. So this is the standard measurement for blood clotting, and it's usually used to monitor the effectiveness of anticoagulant medication, such as warfarin. So a high INR indicates it takes longer for the blood to clot, while a lower INR indicates a shorter time. So this is indicative of some kind of hematological issue. So given these findings, which one of the following best describes this change in the patient's condition? So first we have cholestasis, and this refers to a condition where bile flow from the liver is reduced or blocked. So you can get elevated bilirubin and alkaline phosphatase levels, but it typically doesn't cause significant elevation in ALT or AST. And because this patient does have those levels elevated, it's less likely that it's going to be cholestasis. So enzyme induction refers to the process by which certain drugs or toxins can increase the activity of liver enzymes. So previously in this, obviously, we talked about how carbamazepine has this effect. It increases enzyme induction, and that's why it increases the metabolism of estrogen and progesterone, and why it interferes with contraception. So if we were expecting enzyme induction, yes, we would see elevated liver enzyme levels, but we wouldn't typically expect significant elevation in bilirubin or INR. So again, that's leading towards something else. So liver psoriasis is late-stage liver disease, and that's characterized by scarring of the liver tissue. So this is something that we might be thinking about, especially because we had heightened levels of ALT, which would be indicative of some kind of inflammatory process going on. However, it doesn't typically cause significant elevations in bilirubin or in INR unless there is decomposition. So in this particular case, it's not giving us the full picture of what's going on. So the correct answer in this case is ongoing hepatocellular damage. So if we just quickly scroll up again, so we can see here a bilirubin is elevated, so that indicates jaundice occurred during liver function or obstruction of the bile ducts. Alkaline phosphatase levels are normal, so if that was elevated, we'd be thinking cholestasis, but because it's not, it's less likely to be that. Alanine aminotransferase, and to be honest, aspartate aminotransferase, both of these are very similar. So both of these are enzymes typically found within hepatocytes, so within liver cells specifically. And both of those, if they're elevated, they are indicative of hepatocellular damage. Then you have GGT, or gamma glutamyl transpeptidase. That tends to be elevated in liver and bile duct disease, but it's particularly sensitive to bile duct obstruction. So this one isn't elevated, which again, along with the alkaline phosphatase levels, it's more indicative that there is a problem with the liver, yes, but it's not a bile duct obstruction. So whenever you're looking at an LFT like this, alkaline phosphatase and GGT, both of these are leading you towards some kind of biliary obstruction. And then finally, elevated INR, so that indicates impaired blood clotting function, and this could be due to liver dysfunction. So given the combination of elevated bilirubin, ALT, AST and elevated INR, along with the other symptoms they're describing, so you have that itching, nausea and jaundice, out of all of the answers we have, the most likely explanation is ongoing hepatocellular damage, which is suggested that the patient's liver function is going to continue to deteriorate, and that's going to lead to worse liver function testing and increased clinical symptoms. So it's something that we will need to address. And then finally, just the last one, so possible alcohol abuse. So yes, alcohol abuse, as you imagine, I mean, that's the joke, isn't it? Going down for 8 pints and my liver's feeling it today. Yes, so alcohol abuse can cause liver damage, elevated liver enzyme levels, but it is very rare for it to cause significant elevation in bilirubin or INR unless there is very severe alcoholic hepatitis. And there's nothing in the vignette to suggest that this patient is doing that. If you have a patient that is abusing alcohol that much, there's usually some signs, whether they're unkempt, whether they have, something else that's would suspect that that's going on. And given the fact that she's also quite young at 25, the sheer level of alcohol she would need to drink in order to have that level of abuse is excessive. It's something you expect more in the middle age. Obviously, as we get a little bit older, our organs are not quite as responsive as they used to be. So it'd be incredibly unlikely that you would find it in someone of this age. So in this case, all of the different signs, so bilirubin, INR, is much more suggestive of an acute liver injury rather than chronic alcohol abuse. Question 85. Which two of the following actions are appropriate to manage this change in the patient's condition? So for this patient, there are two things we need to do. First of all, we need to figure out why there is ongoing hepatocellular damage so we can stop it. And then we need to deal with the symptoms that she's experiencing, particularly this itching or this pruritus that she's having. So add a fibrate such as a bezafibrate to therapy. So fibrates are primarily used to treat hyperlipidemia, and they do this by lowering triglyceride levels and by increasing the high density lipoprotein cholesterol levels. So they decrease the bad cholesterol, increase the good cholesterol, and with that they can help get rid of some of the lipids. And in this patient, the pruritus, the itching that she's experiencing, is most likely caused by an excess of bile acid buildup, and that can have this itching effect, especially when you have heightened levels of bilirubin. The reason we don't choose a fibrate is because, yes, while it might be helpful for the treatment of itching, it can help deal with that. It's typically used to treat hyperlipidemia, so it's not the first line agent we would go for, because instead what we would go for is to add a cholestyramine therapy to the mix. So cholestyramine is what's known as a bile acid sequestriant. And what it does, it binds to bile acids in the intestine, and by doing so, it prevents the reabsorption of those bile acids into the body and promotes their excretion. So by reducing the concentration of bile acids in the bloodstream, it helps alleviate that itching associated with the buildup of these bile acids. And cholestyramine is specifically indicated in the treatment of pruritus associated with some kind of liver problem. An important side effect, because you're not reabsorbing the bile acid, it can have some unwanted side effects. So, just think logically. If more bile acid is being secreted out of your intestines, what's going to happen? You're probably going to get diarrhea. And that's one of the unfortunate side effects, but I think most people would agree. You'll take diarrhea over liver damage 10 out of 10 times. So next we have add sodium valproate therapy. So sodium valproate is another anti-epileptic drug. So adding sodium valproate to the therapy, if we're not doing anything else, if they're still on carbamazepine, then we run the risk, if we have both of them together, then we run the risk of overstimulating what we're trying to solve. So you don't want to just be adding another epileptic therapy if we're not addressing the initial concern. And the initial concern is that carbamazepine is likely leading to this hepatocellular damage. Add to the fact that if we're adding another drug on, chances are we're just going to increase not only the damage to the liver, but then potentially lead to hepatotoxicity. So really bad idea. Increase the dose of carbamazepine. No, terrible idea. Carbamazepine is likely why the liver is suffering at the moment. So if we increase the dose of carbamazepine, what's going to happen? We're going to make the liver even worse. So dreadful idea. Don't do that. Reduce the dose of carbamazepine. So that might seem like the likely other way, But you have to remember the patient's initial complaint. They have epilepsy and they're taking this to stop their epileptic fits. So if we reduce the dose of carbamazepine, there is a risk that it's now no longer going to have a high enough therapeutic range that she's going to start having those epileptic seizures again. So that doesn't really solve the issue. Rehydration. So rehydration can help manage patients with symptoms of like nausea and dehydration. And ironically, down the line, if she does start to suffer because we've given her cholestyramine therapy and her diarrhea gets too severe, then we might consider rehydration. But hopefully, and most of the time, although diarrhea is a side effect, it's usually not severe enough to be causing dehydration in the patient. So in this particular case, there's no reason to think that she needs rehydration, which gives us the second correct answer, which is actually stopping the cause of this liver damage, which is to stop the carbamazepine under the cover of a new anti-epileptic drug. So because this patient has severe hepatocellular damage, as indicated by her liver function test, it is appropriate to stop that medication because we do not want her symptoms to get worse. It's very likely that the hepatocellular damage is drug induced and is causing these problems. However, if we just stop her on the carbamazepine, then she's going to start having epileptic seizures again. So we need to replace the carbamazepine with a new drug that hopefully will be less aggressive, cause less problems to the liver. That way we can control both of her seizures and also stop the deterioration of this hepatocellular damage. Question 86. Which one of the following drugs might also be added second line to provide relief from her symptoms? So this is referring specifically to that itchiness that she's having. And we have to kind of think, okay, why is she getting this itchiness to begin with? Because there's several different reasons why you might get it. It could be a skin condition. It could be damage to the brachioradialis nerve or some other kind of neurological damage. But in this case, she has a liver problem. And so it's most likely caused by some kind of liver issue. And if it's caused by a liver issue, how is that leading to itching? It's probably leading to some kind of inflammation. So with that in mind, which of these is going to help with that? Would it be a benzodiazepine? So these depress the central nervous system, usually commonly used to treat insomnia, seizures, anxiety, things like that. They do have sedative effects, so they can have an effect if it's a neurological type of itching, but it's not something that you use to treat pruritus, and especially not if it's caused by dysregulation of the liver. A drug with class 3 antiarrhythmic action, such as amiodarone. So these are obviously used as cardiac drugs. They're used to treat arrhythmias. Not going to help with itching, so not that one. A non-selective beta-adrenoceptic antagonist, such as propranolol. So propranolol is used to treat, again, irregular heartbeats. It's sometimes used for patients who are suffering with certain mental health problems, particularly if they have anxiety and they have quite a lot of palpitations. Again, not going to help with itching. So the correct answer here is an antihistamine. So how antihistamines work? So normally you have histamine, and this is the substance in your body that is involved in allergic reactions. And histamines can sometimes contribute to the itching. You know, whether you've had like a bee sting or something like that, it gets red and it gets inflamed and it itches like hell. And part of the reason for that is because histamine causes blood vessels to dilate and it increases blood flow to the affected area. And this increased blood flow can lead to the itching that's caused. So how antihistamines work, they block the action of histamine, and as a result they will reduce the effects of itching that you're going to have associated with that increased inflammation. Great things such as loratadine as an antihistamine is that it's what is known as a second generation antihistamine, which means it's less likely to cause drowsiness compared to first line antihistamines, which makes it the preferred choice in this particular case. And then finally, we have an antimuscarinic agent such as atropine. So antimuscarinic agents work by blocking the effects of acetylcholine, transmitter that's involved in neurological functions. Again, they can have a sedative effect, quite similar to benzodiazepine. So if it was a more neurological condition, maybe we'd be looking at that a little bit. But as this is, we can fairly safely assume it's caused by the liver, we're not going to be using it. So antihistamine. Question 87. A 50-year-old woman has been diagnosed with Graves' disease, also known as hyperthyroidism, and has been initially prescribed carbimazole 40 milligrams daily. Carbimazole is associated with which one of the following adverse effects? So the first one we have is metabolic enzyme induction. So that's kind of what we was talking about before, when it increases the ability of enzymes to undergo metabolism. And as far as we're aware from the biochemistry involved, carbimazole does not do that. The way that carbimazole works is that it inhibits the enzyme thyroid peroxidase. So this enzyme is necessary for the synthesis of thyroid hormones T3 and T4, hence why it's used as a endocrine medication. And so it blocks thyroid hormone synthesis, and by doing so, it helps to reduce the level of thyroid hormones in the body. So this is how it treats hyperthyroidism. Unfortunately, it has side effects. So carbimazole not only affects the synthesis of thyroid hormones, but it also affects the bone marrow, which is where blood cells, particularly white blood cells, are produced. So in doing this, it suppresses the production of white blood cells, which include obviously neutrophils, and this suppression can lead to a decrease in the amount of neutrophils circulating the condition, which is what we refer to as neutropenia. So one of the risks associated with carbimazole is the fact that it reduces the amount of white blood cells in the body, and as a result it increases the risk of infection. So if ever you are prescribing this for Graves' disease, that's something to take into consideration, is the fact that it can have a negative effect on their immune system. So you have to be particularly careful if it's an immune compromised patient, and make sure you consult them appropriately. So the other ones we have, so polycythemia, so that's an increase in the number of red blood cells. So whilst it does affect the bone marrow, it doesn't lead to an increase in the amount of red blood cells. Renal damage, as far as we're aware, there's no significant evidence to suggest that carbimazole causes renal damage. So any adverse effects in the kidneys, they're not common side effects of carbimazole. And then finally we have thrombophilia. So this is a risk in developing blood clots. This again is not something that we associate it. In fact, most anti-thyroid medications are more commonly associated with bleeding tendencies. So it's more likely that you're going to bleed more, and as a result have a decreased risk of a blood clot as opposed to an increased risk of a blood clot. So that gives us the correct answer of neutropenia. Question 88. A 35-year-old woman reported to her doctor with frequent attacks of migraines which had failed to respond to simple analgesia. She's also taken a combined oral contraceptive. For this, her doctor prescribed sumatriptan 50 milligrams and also changed her to a progesterone-only pill for contraception. Which one of the following best describes the mode of action of a triptan? So migraines are a bit of a weird one in that we don't fully understand what causes them. For the longest time, it was believed that they seem to be affected by changes in cranial vasculature, which does seem to have an effect, especially in relation to triggering migraine attacks, but we know that's not the full story. We do know, however, that certain medications can help treat them, and we do know the mechanisms of actions of these drugs. And from that, we can infer reasonably what's going on. So let's have a look at triptans. So how do triptans work? So triptans are what are known as selective agonists of serotonin. And whenever you're thinking of serotonin, and I know it's not the most logical. When you're thinking of serotonin, think 5-HT. That refers to serotonin. So triptans are agonists of serotonin receptors, and they specifically target the 5-HT1B and 5-HT1D, so beta and delta receptor subtypes. And we know that activation of these receptors leads to two things. It leads to vasoconstriction of dilated cranial blood vessels, which may sound counterintuitive, but it's believed that when the cranial blood vessels are dilated, part of the fact that they're dilated causes certain pressure buildup, and that's what leads to migraine. So we actually want to constrict these blood vessels. In addition to that, it also leads to inhibition of pro-inflammatory neuropeptide release. So triptans are used to help treat migraine, headache pain, so other forms of pain in the head, nausea, and also sensitivity to light and sound. So this is a serotonin agonist. So the next one you have here, 2-HT2 receptor antagonist. This is a different type of serotonin receptor, but the key giveaway here is the fact that it is an antagonist. Triptans are agonists, not antagonists, so it's not that. We have causes vasodilation to reverse an attack. No, quite the opposite actually. It causes vasoconstriction to help alleviate the pain. Something that would cause a vasodilation in the vasculature is something you'll think about, like nitroglycerine. And nitroglycerine is used to treat angina, so angina pectoralis, so pain in the chest. So not something to do with migraines. Inhibits reuptake of 5-HT, so inhibits reuptake of serotonin. This is more the purview of tricyclic antidepressants, so particularly something like amitriptyline. And it's believed that they exert their analgesic effect by inhibiting the reuptake of serotonin and norepinephrine, or noradrenaline, depending on your region. They're not first line for the treatment of acute migraine attacks. They're sometimes used for migraine prophylaxis, so to try and stop migraines from occurring in the first place, but they don't work they're not first line for a migraine. And then you have prostanoid receptor antagonists. So prostanoid receptor antagonists are the purview of non-steroidal anti-inflammatory drugs. So we're thinking ibuprofen and naproxen. And these exert their effect through inhibition of the enzyme cyclooxygenase, also known as COX, and that leads to a decrease in the production of prostaglandins. Prostaglandins are involved in the inflammatory process and pain signaling, and they are thought to play a role in migraine pathogenesis. Again, we don't fully know the full picture. So yes, if you're suffering from a migraine, ibuprofen is probably a pretty good thing to help with that, but it's not the same mechanism of action of a triptan, and this question is asking for mechanism of action. So we have the answer. It's a serotonin receptor agonist. Question 89. The oral contraceptive was changed because of which of the following? So the first two are kind of just different sides of the same coin. It reduces the effectiveness of sumatriptan, or sumatriptan can reduce the effectiveness of the oral contraceptive. And as far as we're aware, there's no significant drug interaction between either of these, so this would not be the correct answer. The combined oral contraceptive is a 5-HT, so a serotonin receptor antagonist. So it's arguing that it does the opposite of sumatriptan, and this is an incorrect statement. So combined oral contraceptives contain both estrogen and progesterone. They are not involved in the serotonin pathway at all, so it's just no. Sorry, I'm running out of ways to explain it. No, it's not that. I think at this point we've gone through these quite a lot, so I could probably be a bit short of my explanations. There is an increased risk of nausea. So that is something that can occur with the contraceptive pill, as I'm certain many people are aware. But having it combined with a triptan doesn't increase the risk of having nausea. Again, they work on two separate mechanisms, and to the best of our knowledge, there is very little to do with the interaction between those mechanisms that could cause that. The one area that they do interact with in relation to this question is that there is an increased risk of blood clots. So How this happens is, although they work on different mechanisms, they both can have an effect on your vascular system. So the combined oral contraceptive pill, and in particular the estrogen that's contained in it, has been known to increase the risk of blood clots. And it does this by promoting the production of clotting factors, which reduce the ability to dissolve blood clots. Sumatriptan, on the other hand, as we just saw earlier, it causes narrowing of the blood vessels, and this is one of the mechanisms by which it decreases the risk, or I should say decreases the symptoms associated with migraine. So they're working on two separate systems, but they kind of converge when it comes to the vascular system. So what happens if you have one drug that increases your risk of forming a blood clot and another drug that causes vasoconstriction of arteries, particularly arteries in your brain? Well, you're going to have a risk that if there is a blood clot, it's going to end up in a blood vessel which is now so narrow that it's going to get stuck and cause a stroke. So it is very, very important that when you have a patient on a triptan, that they are not on the combined oral contraceptive. And the reason that the doctor changed them to progesterone, or progesterone only I should say, is it's because the estrogen specifically in the combined oral contraceptive is the main contributing factor in producing those blood clots. So by changing the patient onto a progesterone only contraceptive, we therefore reduce the risk of them both interacting and causing a stroke. Question 90. If the sumatriptan fails to control the patient's migraine, which one of the following is not a reasonable preventative treatment? So the first one we have is a serotonin receptor antagonist, such as pizotifan, and this is used for migraine prophylaxis. It's used to reduce the risk of migraine, which can be very counterintuitive at first to wrap your head around, because obviously sumatriptan is a serotonin agonist, and that seems to reduce the effects of migraine. So why on earth does a serotonin receptor antagonist also have the same effect? And the key point here is that although they are both work on serotonin, the triptans work on a different receptor, and as a result have slightly different effects. So triptan works on beta and delta receptors, whereas pizotifan works on this HT2 receptor. And one of the effects of working on the HT2 receptor is that it has antihistaminic properties. So it reduces histamine, and that's one of the ways it's believed it helps to reduce the effects of a migraine. Next we have a beta blocker such as propranolol. So propranolol is used for a range of cardiac issues. It's also used for mental health. One of the ways that they work is by blocking the effects of adrenaline or epinephrine, and as such they reduce the excitability of blood vessels, and this also goes over into reducing the excitability of nerves in the brain. Again, like I said, migraines are a very complex area and we're not fully aware of how it all interacts, but beta blockers are a drug we use to deal with migraines. The one that would not be appropriate in this is a strong opioid. So morphine, obviously, as I'm certain everyone is aware, is a very powerful analgesic. So yes, it's useful for dealing with pain, but the reason we don't recommend it is, well, quite a few reasons, which probably seem quite obvious. So opioids have the potential for tolerance, dependence, and addiction, and I'm certain most people are aware that unfortunately people can get very addicted to opioids. In fact, I'm just reading the other day about there being a massive opioid crisis in America because people get addicted to painkillers, and it is something we have to be careful of. In addition, it can actually be counterproductive. So opioids can cause medication overuse headaches. So if you use opioids too frequently, it can actually cause you to get a headache known as a rebound headache. So you've taken the opioid to try and deal with pain in your head, and as a side effect, it's now just giving you pain in the head. So it's not something we're going to use. There's very little long-term scientific evidence to support its efficacy for preventing migraines like long-term. So yes, it's a very powerful drug in the short term, but we don't want to be using it long-term. And in addition, opioids have a huge risk of side effects: sedation, constipation, nausea, and because it's so powerful, it can actually lead to respiratory depression. So it is a very powerful analgesic that we only want to use sparingly. We're not going to give it out willy-nilly because someone has a migraine. So we'll just quickly run through the other ones. So a tricyclic antidepressant such as amitriptyline. So amitriptylines are very effective at treating migraines. They work on serotonin levels and norepinephrine in the brain, so that helps to reduce the frequency and severity of migraines. And then finally we have sodium valproate, so that is an anti-epileptic drug, but it's also used for migraine prophylaxis, and it works by stabilizing electrical activity in the brain. And it's believed that this stabilization effect helps prevent migraines by reducing the sensitivity of the trigeminal nerve, and that is at the major nerve associated with migraine pathophysiology. So I just want to finish this up talking briefly about amitriptyline, because amitriptyline is a drug that for the longest time confused me because it just seemed to pop up in all of these different areas. And I just wanted to have a very quick rundown just in case there's anyone else out there that got as confused by it as I used to, just so that you can understand what's going on a little bit better. So amitriptyline, the reason why it pops up in a few areas is because it kind of has multiple mechanisms of action. So one area it does is that it blocks the reuptake of neurotransmitters, but particularly serotonin and noradrenaline in the presynaptic neuron. So this leads to the increase in concentration of these neurotransmitters at the synaptic cleft, which enhances neurotransmission and improves mood. And as a result of that, it's used to treat major depressive orders because it increases the level of serotonin, so it helps to improve mood and reduce symptoms of depression. Okay, that makes sense, right? Fantastic. That's all good. Another area that it works on is it's an antagonist of histamine H1 receptors. So amitriptyline has antihistamine, I always butcher this pronunciation, antihistaminergic properties, and that contributes to its sedative effect. As a result of that, it's sometimes treated off-label usually, but it can be used to treat patients with insomnia, and especially in patients who are also suffering from depression. It's not too commonly prescribed for anxiety, but it has been in the past, and it does have a bit of an effect at dealing with generalized anxiety disorders and dealing with panic disorders. So sometimes you can see it crop up in patients like that. And now the other way it works is it blocks alpha-1 adrenergic receptors, and this leads to peripheral vasodilation and a decrease in blood pressure. And this is part of the reason why it's used as a migraine prophylaxis. It helps to reduce the frequency and severity of migraines, as we just discussed. But all of these different systems together also helps it contribute in another area, and it's used to treat chronic pain conditions, particularly neuropathic pain. So that's pain that's caused by nerve damage, and it is sometimes, I know gabapentin is another one that's quite often used, but amitriptyline is usually the first line if I'm not mistaken, and tends to be favored a little bit more than gabapentin because gabapentin is actually abused a little bit on the street, so it has a street value, so to speak. So amitriptyline can help reduce nerve pain, particularly that caused by diabetic neuropathy. So one of the effects of diabetes is that it can cause nerve damage, which can lead to some horrible side effects. In fact, I saw a patient not too long ago who had lost movement in her lower legs as an exacerbation of her pre-existing diabetes. And it can also help with what's known as post-herpetic neuralgia. So that's nerve pain that tends to occur after an episode of shingles. So amitriptyline tends to be the first line for nerve pain, it's used for depression, and it's also used for anxiety and sleep disorders. So it does quite a lot of different stuff, and I just wanted to cover all of that real quickly just so that you're a little bit aware of the many mechanisms in which amitriptyline works. But anyway, that's all from me. Thank you very much for watching, and I will catch you in the next one.